Hello, my name is David Couteur. I'm a geriatrician and a scientist interested in ageing rather than dementia per se. Before commencing this talk, I should point out that all of the people talking to you today share a common goal, which is to improve the lives of people with dementia and try and reduce the risk of people developing dementia in the first place. But today we've been asked to give opposing points of view regards the issue of dementia case finding, and I've been asked to focus on the harms of dementia case finding or the argument against dementia case finding. Before talking about dementia specifically, I should put this into a broader perspective, because the earlier diagnosis of dementia is part of a major and I think a very worrying trend in all areas of modern medicine to increase diagnostic labels, to increase the numbers of people with various diagnoses from a whole range of diseases. In fact, it's been such a concern that the British Medical Journal a number of years ago launched the overdiagnosis movement. This was led by Ray Moynihan, an Australian, and as pointed out in this article, their concern is that evidence is mounting that modern medicine is harming healthy people through ever earlier detection and ever wider definition of disease. As part of this overdiagnosis movement, I was asked to focus on the problems of overdiagnosis in terms of dementia, and wrote this article entitled "The Political Drive to Screen for Pre-Dementia is Not Evidence-Based and Ignores the Harms of Diagnosis." This article was written with Jenny Doust and Helen Creasy from Australia and Carol Brain from Cambridge University in the UK. Much of the talk today will draw on this article from a few years ago. So the British Medical Journal is concerned by overdiagnosis for the following reason. They argue that the overdiagnosis is not driven by necessarily a desire to do good for patients, but by financial and political motives, by people that serve to make money out of a broader number of patients, and people that have a political motive, i.e. they want to raise the profile and importance of their particular illness of interest. So this leads to more patients through screening or by lowering the diagnostic criteria so more people can be labelled with a particular disease. This will lead to more profits from tests and treatments that are undertaken, but unfortunately will also lead potentially to more harms from unnecessary interventions. And that's what I'll be focusing on in terms of dementia. The British Medical Journal argues that it is not enough to say that untested innovations such as screening should be introduced because the disease is important or that it should work, that we must demand research, clinical trials and good quality scientific proof that interventions, including dementia screening and case finding, are doing more good than harm before rolling them out into the community. To give you an idea of how this overdiagnosis process works, I'll show you some results from an article published in PLOS One a few years ago, written by Ray Moynihan. This study was a study of expert groups that make recommendations about diagnosis and screening of many diseases. And they found that nearly all international expert groups that were convened to make decisions about diagnostic criteria led to decisions that increased the number of patients that would be diagnosed with a disease, and none reduced the number of patients that would potentially be diagnosed with the disease. And they did this by demanding screening, by creating pre-diseases, by lowering the diagnostic thresholds for the diagnosis of an illness, and recommending earlier diagnostic methods. Sadly, 75% of these so-called experts had financial vested interests, i.e. they served to make personal money out of the fact that there will be more patients diagnosed with a disease. And this study certainly included various Alzheimer's disease groups. So with this broader perspective of a movement across a whole area of medicine, I will now focus on dementia screening and case finding. So these terms are thrown around: screening, case finding and timely diagnosis, and the differences between them are somewhat subtle. With dementia screening, what we are proposing is a study or a screening process that involves studying all people in the community. So this would be all people regardless of age, attending general practice, emergency departments, or even doing screening processes in the community. Case finding means focusing this screening process just on people at high risk of the disease. This may include people who have risk factors for the disease or people that maybe have very early symptoms of a disease. Timely diagnosis, however, refers to diagnosis when a patient or perhaps their family come to a doctor and complain of particular symptoms and are asking for investigations and diagnosis. So the sort of things that might convert screening to case finding in terms of dementia are: 1, just being old. Old people are at high risk of dementia. Perhaps a third to a half of people in their 90s will have some cognitive impairment which may or may not be called dementia. So case finding and screening are identical in older people because older people are at high risk of dementia. The sort of minor symptoms that might lead to a doctor being concerned about dementia or early dementia in a patient can be very subtle things. For example, the doctor or the patient may just in passing say, "Do you have any memory problems?" Or the patient might just say, "Oh, I forgot my Medicare card," or a phone number. That would be sufficient for a doctor to be able to go from doing screening for dementia to doing case finding for dementia. So I think it's important to note that for older people, case finding and screening are essentially identical. That what we're talking about is in younger people, those with early symptoms, but in older people, all older people being testing, because that is the definition of case finding. A very important distinction between screening and case finding versus timely diagnosis is that for screening and case finding, it is the doctor that's initiating the diagnosis. It's the doctor that is deciding that a patient may be at high risk of dementia or has had some symptoms of dementia and embarks on the screening process. This is in contradistinction to timely diagnosis, where the patient initiates the diagnosis, where the patient comes to the doctor and might complain of problems with memory or problems with behaviour, or their family might complain about these issues. This is very important, particularly when one thinks about ethical issues such as autonomy or consent. So there are some general questions that we should ask about any medical and health interventions, including dementia screening and case finding, and to me they fall into 3 groups. The first question we should ask is the intervention ethical? Does it do good? And does it do more good than harm? Is there autonomy, i.e. is the patient having genuinely informed consent? And is there justice, i.e. is the process or the program fair for all groups in the community? With respect to screening and case finding, we have a specific set of criteria that have been developed by the World Health Organization called the Wilson-Yugna criteria. These need to be fulfilled before we roll out a screening and case finding program into the community. And the third thing that is important to look at is whether the intervention is supported by independent international organizations who have reviewed the literature and have reviewed the data and made decisions based on consensus about whether the intervention is valuable or not. When we consider dementia screening and case finding, the answers to all of these questions are no. We don't know whether dementia case finding does good, and we have concerns that it may cause harm. The diagnosis is driven by the doctor, therefore we have concerns about autonomy, and the process will be aimed at older people simply because they're old, so the issue of justice is of concern. In terms of the World Health Organization Wilson-Yugna screening criteria, the majority of these criteria are not met. And is it supported by independent international organizations? The answer is no. All of the independent international organizations with an interest in dementia recommend timely diagnosis, i.e. diagnosis that is made at the time where the patient has concerns about their problems. So the usual arguments put forward for dementia screening and case finding are as followed. Only about 1/2 of people with dementia are diagnosed. This is used as a major political point in the United Kingdom. But the issue is, whether diagnosing the other half of people with dementia is of any value to them. The second point that is made is that dementia is important, and of course I agree with that. However, the issue is whether screening will do anything to improve the lives of people with dementia. And the third point that is usually put forward is that we can give advice and support to people with early diagnosis that may be useful to them. It's important to understand a little bit about the history of dementia screening and dementia case finding, and this does fall into the domain of overdiagnosis as put forward by the British Medical Journal. Dementia screening and the subsequent assessment in memory clinics were initially promoted in the UK by the pharmaceutical companies to extend the market for their dementia drugs, and then became very much supported by clinicians and academics who quite justifiably wanted to promote dementia at the political level. UK doctors are now paid a bonus for every patient they send to a memory clinic. The usual arguments against dementia screening and case finding can be summarised as follows. The tests, which are mostly questionnaires and scans, are inaccurate, especially in older people. The second point is that there are no specific interventions to treat or slow the disease. If we screen or case find and make a diagnosis, we cannot offer our patients any particular treatment. All that we're doing is giving them a diagnosis. In terms of the advice that could be given to people with early dementia, every single piece of advice that can be given to someone with dementia should be given to everyone that's getting older, regardless of their cognitive status. The fourth point, which I will discuss shortly, are there are potential harms from early diagnosis, from case finding and from dementia screening in older people. And the final point, as I'll show you, is there is no research yet that shows that dementia screening and case finding works. And in fact, some of the studies show that it doesn't work in terms of patient-related outcomes. So there has been one piece of research recently published that looks specifically at the value of dementia case finding. This was published in 2016, and the study was done in the Netherlands. What the study involved was putting practice nurses into general practices, and they were asked to screen older people who perhaps had symptoms or early signs of dementia or cognitive impairment. And they screened 7,865 people over the age of 65 years. A subset of the newly diagnosed patients, or those that were found to have some cognitive impairment, went on to have the education, advice and care plans that are promoted as being useful for people with early dementia. Interestingly, only a quarter of the subjects that had had this early diagnosis agreed to be involved with this. What were the outcomes? Well, there were no significant increases in the diagnosis of dementia, so the case finding didn't work. The second point is that there were no improvements in the quality of life, the mental health scores, or the number of social supports provided to the patients over the subsequent 12 months. The authors of this large study, and the most important study in terms of making decisions about case finding, argued the following, or concluded the following. At present, we cannot recommend case finding of mild cognitive impairment, which is sort of an early dementia, and dementia among persons in whom family practitioners consider cognitive impairment or dementia possibly present. But what about the benefits of giving people advice and support? Surely we would expect that to be useful. This was a large study that looked specifically at this, whether there is any benefit to patients and their families of providing early advice and psychosocial support. This study was done in Finland and is called the AL-SOLVA study, and this was the largest and longest study of early psychosocial interventions in people with early dementia. So they looked at 236 people with early dementia, not diagnosed by case finding, but by other methods, and they were given education, counselling, and provided with social support, and they were followed over the next couple of years. At the end of the 3 years, they found no difference in nursing home admission, and no differences in other outcomes, including cognition, function, behaviour, quality of life, or carer well-being. And they noted that previous studies that are cited to support psychosocial interventions were in patients who had more advanced dementia, where the behavioural problems were perhaps more obvious and where the psychosocial supports were more useful. Just in passing, I'll show you this rather complicated figure that looks at the cumulative incidence of the need to go into nursing homes comparing the two groups, those that had the psychosocial intervention and those that had the control, and the data were collected over 3 years. And what this shows is, although there was no significant difference between the entry into nursing home between the interventions and the controls, there was a trend towards people having the intervention entering nursing home more frequently than those that were left to their own devices. So in terms of advice given to people with early dementia, which is the main reason that those people that are proponents of case finding and screening put forward, I would argue that these two clinical studies showed no benefit of early psychosocial interventions, and any advice or support that is given to people with cognitive impairment should be given to all older people regardless of their cognitive function. And the sort of advice that we might be wanting to give to people with early dementia is exactly the same as the advice that we might want to give all older people, and it includes the following: stop medications that are bad for the brain, exercise frequently, eat well, don't smoke, get your affairs in order, and think about organising advanced care directives. So having discussed the evidence for dementia case finding, which is absent, I will now put forward some of the concerns around the potential harms of dementia screening and case finding. One of the first concerns is that the tests are not accurate. So many people who undergo a case finding or screening process will be incorrectly diagnosed or may be incorrectly reassured. Here I put forward the results of a particular study published in 2011, and it was concluded that if a general practitioner saw 100 older patients, of whom 6 had dementia, and undertook a case finding or screening process, they would say that 30 of these 100 people should go on to have additional testing, and this additional testing would correctly diagnose 3 of the 6 patients with dementia, but would tell the other 3 of these patients that they were normal, and problematically would identify another 3 normal patients as having dementia. But what if we go on to do the various brain scans and lumbar punctures, the high technology investigations that are sometimes promoted to diagnose Alzheimer's disease? I would argue that in older people, the results of these tests are little more than coin tosses. They're not terribly accurate, and they're not recommended by any international groups, including the major organisation that looks at evidence-based medicine, the Cochrane Review process. People might argue that they would like to know what's going to happen in the future. Well, one of the problems is that it's very hard to predict what will happen to people with very early cognitive and memory problems. If we find people through case finding and screening with very early memory problems, we can't actually give them very strong advice about what will happen to them in the future. So what does happen to people who have early minor cognitive impairments and memory loss? In terms of mild cognitive impairment, which is usually considered to be a very early form of dementia, the prognosis or the outcomes is as follows. Less than 10% of these people will progress to dementia, but more than 20% will go back to normal, and the rest are unchanged. So if you have a case finding and you are found to have some cognitive deficits, you've actually got double the chance of going back to normal than you do in progressing to dementia. And one of the other considerations is much of this screening will be picking up problems in very elderly people who are in fact likely to die of other illnesses before their dementia becomes a problem. So what is the value in saying that they would go on to develop dementia if they lived long enough, if they're going to die before the dementia occurs? The testing process itself has potential and real risks. What would generally be recommended if the case finding turned out to be positive, if someone would be referred to a memory clinic where they would undergo neuropsychological testing and possibly scans, and in some centres a test called a lumbar puncture, which involves putting a needle into the spine to take off fluid around the spine and the brain. Research in the United Kingdom, where memory clinics are very common and very heavily promoted, has shown that many people referred to the dementia clinics do have distress, have alarm and feel stigmatised. And as you can imagine, there are adverse effects from having PET scans, MRI scans and lumbar punctures. Another issue is that the investigations are costly. It has been put forward, mostly in the United Kingdom and in Europe, that the typical assessment of cognitive impairment, the neuropsychological testing, the referral to a memory clinic and the scans, costs around 5,000 Australian dollars per person. In the United Kingdom, the memory clinics have become clogged with the worried well, people that have complaints of memory concerns, and those who are depressed. And this has led to a delay in timely diagnosis for those people with real dementia who need to be looked after. And one of the concerns is that all of this money that's being spent on early diagnosis, on screening, on case finding, is spending money on those people that don't need it, where we need to be using those funds to look after people with advanced dementia and their families who have substantial care needs but are missing out because the money is being spent on early diagnosis. As you can probably imagine, there are psychological concerns that would occur in terms of having a very early diagnosis of dementia. This was a study performed in 2015 of just 50 people with early dementia, not diagnosed by case finding, but have just been found to have very early dementia. And it was found that these people, after their diagnosis was made, did complain of social isolation, of feeling rejected, a fear that their diagnosis will be discovered by others, i.e. a sense of shame. They had impaired quality of life, and they had increased rates of anxiety and depression. There have been a number of studies and publications that have drawn attention to the fact that an early diagnosis of dementia may increase the risk of suicide and even euthanasia. So one study showed that the recent diagnosis of dementia in hospital was associated with a 10-fold increase in suicide in the following 3 months. Another study found that 75% of suicides that occur in people with dementia occur shortly after the diagnosis has been made. And there have been suggestions that there are increased requests for physician-assisted suicide, i.e. euthanasia, for people early after the diagnosis of dementia or even before the diagnosis of dementia. This means that people who are perfectly well will say to their doctor, I would like to commit euthanasia if I have a diagnosis of dementia because I don't want to go forward with that illness. There are some legal concerns, so some legal adverse effects of having a diagnosis of early cognitive impairment that might be made as a result of case finding. First is a loss of independence and autonomy. The medical system and the family may say, well, you have been diagnosed with early dementia, and take away your autonomy and your ability to consent to various interventions and other life decisions. It may impact on your health insurance. If you're younger, it may lead to discrimination at work, may have a financial impact, will influence your capacity to change wills, and you may have unwanted activation of enduring power of attorney. If you've completed an enduring power of attorney, then the diagnosis of dementia may activate that power of attorney, taking away your ability to make decisions around money or medical care. I should briefly mention medications. Are there any medications that help in terms of delaying dementia? No. Do these have side effects? Very definitely. So the only available medications for dementia are the cholinesterase inhibitors and another drug called memantine. And these have very modest effect in dementia. Their effect is less than that of doing regular exercise. I should point out that they're ineffective in very early dementia, i.e. the studies have been done in mild cognitive impairment, and they certainly don't influence the progression of the dementia itself. They just have a very slight effect on the survey or questionnaire studies of memory and cognitive function. The side effects in the early part of the treatment are common, including nausea, diarrhea, urinary incontinence, insomnia, agitation, and loss of weight. Although these symptoms may settle with time, it is important to note that symptoms such as incontinence and agitation may in fact increase carer burden. And there are longer-term side effects that are quite serious, including an increased rate of hip fractures and a need for pacemakers because of a very slow pulse rate. So if we don't embark on screening and case finding, what would happen to people in the community who are developing dementia? Well, there has been one study that has considered this, published in 2015, and it suggested that the diagnosis of dementia would be delayed between 10 and 30 months, i.e. if we go from case finding to timely diagnosis at a time where the patient has got concerns. Who would be left undiagnosed? Well, mostly very elderly males who have less education, have milder dementia and less behavioural symptoms, so older men living by themselves that are not causing any harm to themselves or the community. This compares to people where diagnosis is made much earlier, and this is more common in married, educated women where their deficits are picked up much earlier. So if we don't have case finding and we don't do screening, what we end up with is timely diagnosis, i.e. diagnosis when the patient themselves is concerned there is a problem. So my summary and my conclusions are as follows. The evidence that we have to date shows that case finding and screening are not useful in terms of increasing the number of diagnoses or in improving patient outcomes. There are potential and or real harms, and I've mentioned these to you. These include those that are psychological, financial, related to autonomy, and the adverse effects of medical investigations and medications. The British Medical Journal would argue that the motives for such rollout of screening programs are political and financial rather than a focus on patient outcomes. And the alternative is timely diagnosis initiated by the patient and not the doctor, and this is currently recommended by all national and international groups. In this little picture I've shown you an Australian consortium that has put forward the concept that we need timely diagnosis of dementia, and this group includes our general practitioners, the Dementia Training Study Centres, the Dementia Collaborative Research Centres and Alzheimer's Australia. They all propose that currently timely diagnosis of dementia is the preferred option rather than dementia screening and case finding. And I'll finish up with some patient stories which are often more potent than all of the facts and figures and charts. So this is an article published in the Wall Street Journal in 2012 about a patient with an early diagnosis detected through memory clinics and early screening. And the article is entitled "The Curse of a Diagnosis. Is early detection useful if a disease has no cure? An Alzheimer's Dilemma." And it's about a lady aged 56 years of age whose family noticed that she was forgetting things and repeating herself, and her husband, who's 70, who disputed that his wife is significantly impaired and has said that the diagnosis has done more damage than the disease. And the quote by Linda, the patient, aged 57, is that "I guess my wiring is a little off, but knowing it is worse than having it." And her husband Colin, aged 70, who said, "There's no way that this diagnosis benefits people who have it." Thank you.